Hello everyone, hope you're all doing good. In this video, we are going to discuss about gestational trophoblastic neoplasia. So let's start. It is gestational trophoblastic neoplasia. Okay. So this is a neoplasia that develops from any type of pregnancy. Okay, so that is why the term gestational is there. Okay, so it can develop from hydatidform mole. 50% of the cases are developing from hydatidform mole. Then they can develop from abortion, which will include 25% of the cases, or they can develop from a full term pregnancy even, which will include approximately 23% of the cases, and finally some cases can also develop from ectopic pregnancy, that will include 20% of the cases. Okay, so the major contribution to this gestational trophoblastic neoplasia is by hydatidform mole. Okay, but you also have to remember it can develop from abortion, full term pregnancy, or even an ectopic pregnancy as well. Clear? Right. Now let's see the clinical presentation of this group of neoplasia. So clinical presentation, they have very aggressive nature, that they will invade into the myometrium, and some tumors also have a tendency to metastasis. Okay, metastasis is also seen in some people. So the clinical features will include uterine bleeding, that can be a continuous bleeding or an intermittent bleeding, that sometimes can present even as a sudden profuse hemorrhage. Then after delivery, the uterus doesn't involute back to its normal size, that is uterine subinvolution after any delivery or miscarriage. They can even present with perforation that can lead to intraperitoneal hemorrhage. In some women, the metastasis of these tumors will be going back to the lower genital tract, and in the vagina, this will be seen as bluish vascular mass. Clear? Right. Now let us discuss about the investigations you have to offer this woman. So investigations you will offer will include a baseline serum β-hCG, then a complete hemogram, and then to identify metastasis, will also be doing liver function test, pulmonary function test, a transvaginal ultrasonogram, chest radiography, abdominal CT scan or MRI, and you should also check the CSF β-hCG levels to identify whether the tumor has metastasized to brain. Okay, so this is the basic set of investigations you will offer the woman. One is baseline β-hCG, then a complete hemogram, then your liver function test, then pulmonary function test, transvaginal ultrasonogram, chest radiography. This may even involve, it can even take your CT chest also, then abdominal CT scan or MRI, then CSF β-hCG levels. Clear? Now let's see about the anatomical staging of gestational neoplasia. So, the 4 stages are stage 1 where the tumor is confined to the uterus, stage 2 where the tumor extends outside the uterus, but it will be limited to the genital structures, okay, extends outside the uterus, but it is limited to the genital structures. And stage 3 is when it extends to the lung, okay. That can happen with or without the genital tract involvement, okay. And finally, stage 4, metastasis to any other site other than lung, okay. So, this is how the figure anatomical staging is given for gestational neoplasia. Stage 1, it is confined to the uterus. Stage 2, it extends beyond the uterus and it will be going to the other genital structures, say cervix, vagina, or the tubes, ovaries, like that, okay. Stage 3, metastasis to the lung, okay. So, this staging is very important because this is asked in exams, okay. And stage 4 is metastasis to any other site than lung. Clear? Now, yeah, we also have another staging, okay, that is given for gestational trophoblastic neoplasia, which will be including all the risk factors, okay, like age, antecedent pregnancy, interval months from the index pregnancy, pre-treatment serum β-hCG levels, then what is the size of the tumor, whether it is a large tumor or not, then what is the metastatic site, then how many number of metastases are there, then any previous failed chemotherapy, like that, okay. So, here I want to tell you one thing. The scoring given includes 0, it starts right from 0, then it takes 1, 2, and remember 3 is not there, you will be directly giving 4, okay. So, that is very important, okay. Now, let us see this. Age group will be considering only 2 sets of age group, whether it is less than 40 years or more than 40 years, and you will be writing it here only, okay. So, less than 40 years or more than 40 years, okay, in years, right. Antecedent pregnancy means how was her previous pregnancy, okay. That means whether it was an abortion or a miscarriage or whether it was a full-term pregnancy, like that, okay. So, I will tell you one mnemonic here. Keep in mind MAT, okay. So, MAT, that means mole, abortion, and then term. Clear? Right. Then interval months from pregnancy. Interval months from pregnancy means how many months after the pregnancy the changes started happening. So, it will include less than 4 months or 4 to 6 months, then 7 to 12 months, and then more than 12 months. Clear? Next is pre-treatment serum β-hCG levels. So, these levels are given in milliliter, okay. So, less than 10 to the power 3 units, million units, okay. Then here 10 to the power 3 to 10 to the power 4, then finally here 10 to the power 4 to 10 to the power 5, and finally it is more than 10 to the power 5, okay. So, that is pre-treatment serum β-hCG levels. And the next one is largest tumor size, that will be including the uterus also. So, this includes less than a tumor which is less than 3 centimeter, and then 3 centimeter to 4 centimeter, and more than or equal to 5 centimeter, okay. Here we doesn't have anything, okay. So, I will give you a bright color here, yeah, I am giving a green and circling it where you have no entries, that also you have to remember, okay. And then, so till this you will be starting from the 0 score only, okay. From site of metastasis we are not having any 0 score, okay. So, site of metastasis to spleen and kidney carries 1 score, and if it happens to the gastrointestinal system, then it will be taking 2 score, and if it metastases to the liver and brain, then it will be taking number 4. Okay. Then number of metastasis. Number of metastasis means here also we are not having any value for 0. So, number of metastasis 1 to 4 takes score 1, then 5 to 8 takes score 2, and more than 8 takes score 4. Clear? And the next one is previous failed chemotherapy. If chemotherapy has been used and it has failed, okay. So, previous failed chemotherapy with one drug includes score 2, then if it is involving more than or equal to 2, then it involves score 4. Clear? So, here 2 readings you do not have. Clear? So, this is all about the scoring system for GTN, that is very important. Remember the risk factors it is involving, that is age, antecedent pregnancy, interval months from index pregnancy, pre-treatment β-hCG, larger tumor size, site of metastasis, number of metastasis, and previous failed chemotherapy. The score should be between 0, 1, 2, 3 is not there, it is directly 4. Okay. Age, only 2 age group, less than 40 years and more than 40 years. Antecedent pregnancy will be MAT, that is mole, abortion and term, done. Interval months from pregnancy, months you have to start from 4. Okay. So, that is less than 4, 4 to 6, 6 to 7 to 12 and more than 12. Okay. Then pre-treatment serum β-hCG levels will be given in million units, that means less than 10 to the power 3, 10 to the power 3 to 10 to the power 4, 4 to 5 and then more than 5. Largest tumor size less than 3 centimeter, 3 centimeter to 4 centimeter and more than 5 centimeter, etc. Here you have no reading for 4. Okay. Then for site of metastasis, you should remember it starts only from 1, that is spleen, kidney, number 2, score 2 is gastrointestinal system and score 4 is for liver and brain, right. And we have seen the number of metastasis also and previous failed chemotherapy as well, right. Now, let us see the scores 0 to 6. If they get, then it means they have a low risk disease. Suppose if the scores are more than or equal to 7, then they are considered to be in a high risk group. Okay. Now, let us see about the invasive mole. Invasive mole means there will be a risk from all the other types of moles. Okay. That means it can be a partial mole or a complete mole. Any type of mole carries the risk to become invasive. Then there will be extensive tissue invasion by trophoblasts or whole villi, and invasive means they will be penetrating deep. So, they penetrate deep into the myometrium, parametrium, and sometimes it may even go to peritoneum or the vaginal wall. Okay. And remember, this type of mole which has become invasive has a low risk for metastasis. Okay. So, that is about the invasive mole. And next one is gestational choriocarcinoma. So, gestational choriocarcinoma is a very rapidly growing tumor. This can follow miscarriage or a term pregnancy. And remember, 1 out of 4 cases can follow molar pregnancy. It consists of cytotrophoblast and syncytiotrophoblasts, and this contains no villi. Okay, no villi is there. Clear? So, this tumor, it spread outward and become visible on the outer surface of the uterus as dark irregular nodules. Okay? And in gestational choriocarcinoma, yes, metastasis can happen. Okay? So, metastasis will be going through the blood vessels and they will develop early also. Okay? So, let us discuss what are the sites of metastasis now. This include lungs. I already told you lungs are the most common site of metastasis, followed by the vagina, vulva, kidneys, liver, brain, ovaries and bowel. Okay. So, these are the various sites of metastasis. Clear? It is going to be the lung, vagina, vulva, kidneys, liver, brain, ovaries and finally bowel. Clear? Right. Now, the next category we are going to discuss is placental site trophoblastic tumor. Okay, placental site trophoblastic tumor. So, this tumor is one of the uncommon tumor and it usually arises from the placental site where the placental site of attachment was present. Okay, from there a tumor will be rising and it will be mostly consisting of your immediate trophoblasts, and in this condition the serum β-hCG levels are moderately elevated. Clear? The next one is epithelioid trophoblastic tumor. So, this is also one of the rare tumor in this category. It develops from chorionic type intermediate trophoblasts. hCG levels are low here. Yes. So, this is what you should know. Okay. Let me show you some pics. So, this is a picture of gestational choriocarcinoma where you are seeing so much of invasion. Okay, there was invasion into the myometrium. See, you are able to see the invasion into the myometrium. There is hemorrhage as well as necrosis. Whatever the red thing you see, there is hemorrhage. Okay, and there is also some necrosis. So, this is seen in a microscopic picture in a pathology slide also. Okay, all this red thing are hemorrhage that has happened into the myometrium. And this picture is a placental site trophoblastic tumor that has a growth has developed at the site of the placental site of attachment. Clear? Right. Now, how to manage gestational trophoblastic neoplasia? When GTN happens, gestational trophoblastic neoplasia occurs, it will be further classified into two types. Okay, so one is low risk GTN and another one is high risk GTN. Okay, so low risk GTN will include stage 1 or stage 2 also, which will get a score of 0 to 6. The second classification we have seen, right? The prognostic scoring in that. And for high risk GTN, yes, it is stage, this includes stage 3 also. Okay, stage 1 will be low risk, stage 2 and 3 which take scores between 0 to 6 or low risk. Okay, and high risk means stage 2 and 3 which takes WHO score of more than 7. Okay, and this is stage 4. Clear? Right. Now, let's discuss how to give chemotherapy in this case. Okay, will not be giving chemotherapy for all case. The primary mode of placental side trophoblastic tumor and epithelioid trophoblastic tumor are different. I am just explaining you about the choriocarcinoma. Okay, so how to give chemotherapy. So chemotherapy, as we have told already, see repeating. Chemotherapy, as we have said already, can be classified into single agent chemotherapy or multi-agent chemotherapy. Single agent chemotherapy means we will be using the drug methotrexate. Okay, very important. And multi-agent chemotherapy I will explain you separately. So let's discuss about the single agent chemotherapy and how it is given. So single agent chemotherapy is usually given in multiple doses. Okay, so the dose is 1 milligram per kilogram IM, and this is usually given on the days 1, 3, 5, 7. Okay, and what will you do in the middle in between days? Okay, so like day 2, 4, 6, 8, what you will do means you will give tablet folic acid at a dose of 15 milligram per orally. Okay, and this will be given. Okay, so this will be given for 2 weeks. Okay, so this regimen will be continued for 2 weeks, and that's it. Okay, so one alternate drug you can use instead of methotrexate when there are contraindications to methotrexate, or if you see any side effects of methotrexate means it is actinomycin D. Okay, it is actinomycin. Clear? Right. Now let's discuss about multi-agent chemotherapy. Multi-agent chemotherapy is also known as Bakshaw's regime. Okay, Bakshaw's regime, which will have the drug namely Imaco. Okay, so let's expand this Imaco first. This includes etoposide, M, yes, methotrexate again, then A, yes, alternative drug what I told you, yes, actinomycin, D, then C is cyclophosphamide, and O represents vincristine here. Okay, that is vincristine, or its other name is Oncoven. Okay, so this O is taken here to represent. Okay, so this is the Imaco regimen. Okay, so what is Imaco? That is etoposide, methotrexate, actinomycin D, then C for cyclophosphamide, and finally O means Oncoven, which is nothing but your vincristine. Clear? Right. Now let us see the doses at which these drugs are given. Okay, etoposide is given at a dose of 100 milligram per meter square as an IV infusion in saline over 30 minutes. Clear? So that is all about etoposide. And next drug is methotrexate. So this is given at a dose of 100 milligram per meter square IV infusion over 12 hours. Okay, and the next drug is actinomycin D. This will be given at a dose of 0.5 milligram IV in saline. Clear? And the next drug is cyclophosphamide. This is given at a dose of 600 milligram IV in saline. And the last drug is vincristine or oncovin, which is given at a dose of 10 milligram per IV and stat. Okay, 10 milligram by IV as a stat dose we have. Okay, so these are the drugs that are included in the IMACA regimen, that is otherwise known as Baksha regimen. Clear? Yes. Now, you have to know what are the indications of hysterectomy in these patients. Okay, let's discuss what are the indications of hysterectomy. So, indications of hysterectomy will include stage 1 disease where the fertility is not desired, and when the family is completed for the woman and her age is above 40 years, and next one when she has excessive bleeding, then also in cases of placental trophoblastic tumor and epithelioid trophoblastic tumor. Okay, so if these two tumors have very high stage of presentation, then you can even add chemotherapy. Clear? So these are the indications of hysterectomy. When stage 1, when fertility is not desired, when she has completed her family and above 40 years, and there is excessive bleeding, and especially in placental side trophoblastic tumor and epithelioid trophoblastic tumor, and in these cases you may even add chemotherapy if they are presenting in higher stages. Clear? Right. Next one, let's discuss what happens with the pregnancy outcome after GTN. Okay, so pregnancy after GTN. In these women, you should ideally advise them to delay pregnancy for at least 1 year. Okay, so first point, delay pregnancy for at least 1 year because there can be relapses and methotrexate can persist in the tissue, and then if the woman gets pregnant in case within this 1 year, then what you will do? Yes, you should only reissue her, okay, because it can even have a favorable outcome. So she can reassured that she can have a favorable outcome, and you have to keep one point, there is a higher risk of stillbirth in these people, that can be around 1.5%, and after delivery you should definitely send the placenta as well as the products of conception for histopathological examination, and serum β-hCG levels should be measured 6 weeks postpartum. Okay, so this is how you will follow up a woman if she wants to plan pregnancy. First one, you should advise her not to get pregnant within the next 1 year because there are more chances of relapse and methotrexate will be absorbed into various tissues also. Okay, the risk of methotrexate you have to explain. Then suppose if she gets pregnant, don't tell her to abort immediately. She can be reassured that yes, she can have a safe delivery, but explain that there is a chance of 1.5% of stillbirth, and after delivery her placenta and products of conception should be sent for histopathological examination, and serum β-hCG should be measured after 6 weeks postpartum. Clear? Right. Now let's discuss about the diagnostic criteria for post-molar GTN. Okay, diagnostic criteria for post-molar GTN. So first point is if you see the levels of β-hCG are in a plateau, okay, or in a plateau, that is, there is either rise or fall of only 10%, okay, for 4 measurements take, okay, for 4 measurements during a period of 3 weeks or longer, okay, especially on days 1, 7, 14, 21 you are measuring, okay. In this period, when you have taken 4 measurements of serum β-hCG and still you see that only the serum β-hCG has risen or fallen by only 10% or it is maintaining within the same range, then you have to think that there is a chance of development of post-molar gestational trophoblastic neoplasia, okay. So, the second criteria, the rise of serum β-hCG is more than 10% when you measure during any of this week, okay, during 3 weekly consecutive measurements or any time longer than 2 weeks, okay, say days 1, 7 and 14, clear? So, the same way, you are measuring 3 weekly consecutive measurements or measuring over 2 weeks itself shows there is a rise more than 10%, then it should be suspicious, right? Yes. And the third point, β-hCG level remains detectable, okay, remains detectable even after more than 6 months, okay. And after all these things, definitely when you get a histopathological examination of a placenta, that is or products of conception, that is showing a risk of choriocarcinoma, okay. So, this is the fourth point, okay. So, these are the diagnostic criteria for post-molar GTN. Number 1, yeah, the rising or falling will be within 10% only, or the rise will be going more than 10%, then β-hCG will be detectable even after 6 months, and finally histopathological examination will be showing choriocarcinoma direct, okay. So, this is all about gestational trophoblastic neoplasia, which included a group of disorders we have discussed so far. First one is invasive mole, yes. Second one is gestational choriocarcinoma. Third one is placental site trophoblastic disease or tumor, and fourth one is epithelioid trophoblastic tumor, clear? So, yes, with this we will be completing this video. Until we meet in the next video, keep going, happy learning, take care and bye bye.